Gait is the forward movement of the body using the lower limbs, involving coordinated rotation of body segments. It is the style or pattern of walking, which can vary based on age, sex, mood, or disease. The lower limbs support and carry the head, trunk, and arms, which together make up 75% of body weight. The gait cycle is the sequence of activities between two consecutive initial contacts of the same foot. It consists of two main phases: the stance phase, when the foot is in contact with the ground, and the swing phase, when the foot is not in contact with the ground. In normal walking, the stance phase makes up 60% of the cycle, and the swing phase 40%. The stance phase includes heel strike, foot flat, mid-stance, heel off, and toe off. The swing phase includes acceleration, mid-swing, and deceleration. These phases can be described using both traditional and Rancho Los Amigos, RLA, methods. A visual representation of the gait cycle and its phases helps to understand the sequence of movements during walking. Double limb support occurs when both feet are in contact with the ground, making up about 22% of the gait cycle. Single limb support happens when only one foot is on the ground, typically during the mid-stance phase. Visuals of limb support phases show how the body alternates between double and single limb support during walking. Key parameters for measuring gait include step length, stride length, step duration, stride duration, and cadence. Step length is the distance between heel strikes of opposite feet, while stride length is the distance between heel strikes of the same foot. Cadence is the number of steps per minute. Cadence is influenced by step length, sex, and walking speed. Females usually have higher cadence due to shorter step length. The width of base of support is the distance between the midpoints of each foot, typically 2 to 4 inches. The degree of toe out, or foot angle, is the angle between the line through the heel and second toe, usually about 7 to 4, in normal walking. Determinants of gait include lateral pelvic tilt, knee flexion, knee-ankle-foot interaction, pelvic rotation, and physiological valgus of the knee. These help minimize vertical and lateral movement of the center of gravity, COG, for efficient walking. During walking, the vertical displacement of the center of gravity, COG, creates a sinusoidal curve. Proper gait determinants keep this curve minimal, ensuring efficient movement. Disturbances in this curve can indicate pathology. Lateral pelvic tilt and knee flexion reduce the peak of the cog during midstance. Knee, ankle, and foot interaction smooths cog movement during transitions. Pelvic rotation prevents excessive cog drop, and physiological valgus reduces side-to-side movement. Gait can be impaired by various factors, including age, sex, occupation, clothing, assistive devices, body structure, footwear, psychological state, and disease. Each factor can alter walking patterns in unique ways. Abnormal gait patterns include neurological gait, such as Parkinsonian, hemiplegic, ataxic, scissoring, muscular weakness gait, Trendelenburg, duck walking, gluteus maximus gait, joint or muscular limitation gait toe tip, calcaneal, stiff knee, leg length discrepancy gait, and painful or antalgic gait. Neurological gait abnormalities include Parkinsonian gait, shuffling, flexed posture, hemiplegic gait, circumduction, absence of heel strike, cerebellar ataxia, unsteady, reeling, sensory ataxia stamping, and scissoring gait, legs cross due to adductor tightness. Muscular weakness can cause Trendelenburg gait, pelvic drop, duck walking bilateral abductor weakness, gluteus maximus gait, posterior trunk lurch, quadriceps gait, hand to knee, high stepping gait, foot drop, genu recurvatum gait, knee hyperextension, and more. Joint or muscular limitations can cause toe tip gait, calcaneal gait, hip flexor contracture gait, and stiff knee gait. Leg length discrepancies and pain can also lead to compensatory gait patterns.